The overhead surgical lamps at Brigham and Women's Hospital cast a specific kind of light, wide, white, and without shadow in the center of its field, the kind of light designed to leave nothing hidden within the small territory it owns. Beneath that light, in the mid-morning hours of an ordinary working week, sometime in the early 2000s, Eben Alexander III stood at the operating microscope with both hands in position and the quiet of a practiced surgical theater around him. The suction made its low, continuous sound. The instruments were arranged on the tray in the order they would be needed. The patient on the table was under general anesthesia, their breathing managed by the ventilator's slow, even rhythm, and the region of brain tissue that Alexander was preparing to address was no larger than a walnut, a fact that did nothing to diminish the concentration the work required and everything to illustrate what the work actually was. This was the daily substance of his professional life, not the broad strokes of medicine, but the specific, demanding, millimeter by millimeter attention that neurosurgery requires. The understanding that within a structure of approximately 3 pounds of tissue housed in a bony case, the boundaries between function and dysfunction, between a person's capacity for language and its absence, between the ability to recognize a face and the permanent loss of that ability, were measured in fractions of a centimeter. Alexander had trained in this precision across years at Duke University Medical Center, where his residency covered stereotactic radiosurgery and cerebrovascular surgery and neuro-oncology, 3 distinct subspecialties that together gave him a working knowledge of the brain's architecture that was simultaneously intimate and comprehensive. He knew the tissue the way a person knows a building they have worked in for years, not as a diagram, but as a place with specific rooms, specific distances, specific habits of light and shadow. Duke had given him the foundation. Harvard had given him the platform. His faculty appointment at Harvard Medical School placed him in one of the country's most prominent academic medical environments, and his staff position at Brigham and Women's Hospital in Boston, which he held for approximately 15 years, gave him the clinical volume and the teaching responsibilities that come with that kind of placement. He taught medical students. He supervised residents. He stood at the front of lecture halls and walked through the anatomical principles that govern how the brain produces what human beings recognize as experience, and the principles he walked through were not speculative. They were the settled consensus of a field built across more than a century of clinical observation, post-mortem pathology, neuroimaging, and experimental work. The brain generates the mind. Specific regions of tissue perform specific functions. Damage those regions and you lose those functions in predictable, measurable, reproducible ways. This was not a theory Alexander held loosely. It was the framework within which everything he did clinically made sense. The structure he returned to most often in teaching was the neocortex, the outermost layer of the cerebral hemispheres, folded into its characteristic ridges and grooves, making up the largest portion of the brain's surface, and serving as the anatomical seat of what neuroscience calls higher-order consciousness. Perception, memory, self-awareness, the capacity for language and for abstract thought. These functions are mapped to regions of the neocortex with a specificity that generations of clinical observation have repeatedly confirmed. In a lecture hall at Harvard Medical School in the early years of that decade, Alexander would stand before a projected diagram of the neocortex, the color-coded regions of the cortical map that every first-year medical student encounters in the first semester of neuroanatomy, and trace its layered surface with a pointer while the students took notes in the low light of the auditorium. The frontal lobes here, the parietal cortex behind, the temporal lobes on the sides, where auditory processing and aspects of memory and emotional regulation converge. The occipital lobe at the back, where visual information arrives from the optic tracts and is processed into what the person experiences as sight. Alexander knew this map well enough to teach it in his sleep. He had been teaching it for years. What the map implied for clinical practice was a model of the mind that his surgical work consistently reinforced. When a patient sustained damage to Broca's area, they lost the ability to produce fluent speech, and the loss was specific. Comprehension could remain intact, while production failed, exactly as the anatomical model predicted. When a patient sustained damage to the right parietal lobe, they might develop neglect of the left side of their visual field, failing to register the entire left half of any scene they looked at, even with intact eyes and intact primary visual cortex elsewhere. The brain was, in this sense, deeply legible. Its lesions announced themselves in predictable ways. Its functions were not mysteriously distributed throughout some unlocatable realm, but anchored firmly, demonstrably, and testably in specific tissue. This was not a reductive or dismissive understanding of the mind, so much as an empirically grounded one. It was the model the evidence supported. It was also the model that shaped how Alexander heard the accounts his patients sometimes brought to him from the far side of their surgeries and cardiac events. Not every patient who survived a serious medical event described something unusual about the time they had been unconscious, but some did. Some described floating above the operating table and looking down at the surgical team. Some described moving through a dark space toward a region of light. Some described encounters with deceased relatives or the experience of arriving somewhere vast and peaceful before returning. These accounts came in different forms and different degrees of specificity, but they arrived often enough that a neurosurgeon practicing for as many years as Alexander had could accumulate a small catalog of them, a quiet archive of patients sitting up in their hospital beds, still pale from the procedure, working to describe something they clearly found significant and strange. Alexander listened to these accounts carefully. He was not dismissive in manner. The notes in his patients' charts suggest a physician who took the time to hear what his patients reported, who sat at the bedside and gave the person in the bed his full attention while they spoke. The listening was genuine, but the explanations he carried away from those conversations were clinical ones. Anesthetic effects produced unusual perceptual states in some patients, including vivid hallucinations and dissociative experiences that could outlast the immediate effects of the drug. Hypoxia, the reduction of oxygen delivery to the brain during cardiac arrest or periods of inadequate perfusion, was well documented as a cause of complex visual and auditory phenomena, including the tunnel effect that many near-death experience accounts described. Disinhibition of neural firing in a brain under extreme physiological stress could produce a cascade of activity in areas of cortex normally held in check by the brain's inhibitory systems, generating experiences of unusual vividness and emotional intensity without requiring any source beyond the tissue itself. These were not ad hoc explanations invented to dismiss what the patients described. They were the mechanisms that the existing science offered, and they were coherent, plausible, and consistent with the broader clinical literature. The patients, for their part, often seemed unsatisfied by these explanations. Not angry, usually not that. More often simply quiet, in the specific way of someone who has received an answer to a question they did not quite ask. Alexander noted this, the way a careful observer notes a pattern without necessarily knowing what to make of it. He filed it where he filed most things that didn't require immediate action, in the background, where it continued its existence without particular urgency, the way unresolved questions do. His office at the medical school had the accumulated look of a career spent inside a single demanding field. The shelves held the kind of books that nobody puts in shelves for decoration, the bound surgical atlases with their diagrammatic cross-sections of cranial anatomy, the neuroanatomy textbooks worn at the spine from regular consultation, the clinical manuals for stereotactic technique, the stacked issues of the journals that a practicing academic surgeon keeps current with. A window in that office looked out over a parking lot in early evening light, the kind of view that most faculty offices at research hospitals offer. Not picturesque, but familiar in the way that a workspace becomes familiar over years. The specific quality of afternoon light through that particular glass, something that registers without being noticed. The work happened at the desk, not at the window, but the window was there, and the light changed across it through the years, and the career that assembled itself around that desk was the career of someone who had chosen a specific kind of knowing and had pursued it with consistency and care. There is a quality that long practice in a technical field produces in a person, a particular kind of confidence that is not the same as certainty, but is adjacent to it. Alexander had operated on hundreds of brains over the course of his career. He had performed the microsurgical removal of tumors in regions of cortex where the margin between excision and damage to eloquent tissue was measured in less than a millimeter. He had treated vascular malformations whose rupture would have produced catastrophic bleeding into brain parenchyma with seconds of warning. He had seen, with the clarity that direct surgical experience provides, exactly how fragile the architecture of consciousness is, how a small hemorrhage in the right place could extinguish language, or memory, or the capacity for emotional regulation, or the person's own sense of who they were. This was not abstract knowledge. It was knowledge that came with the texture and weight of things witnessed at close range and repeatedly confirmed. This was the epistemological position he occupied in November 2008, not the position of a man who had never thought carefully about consciousness, but of one who had thought carefully about it for decades within the framework that his field provided, had found that framework adequate to the cases he encountered, and had no particular reason to expect it to be otherwise. His skepticism regarding supernatural explanations for near-death experiences was not the uninformed skepticism of someone who had never encountered the phenomenon. It was the informed skepticism of someone who had encountered it many times and found the available clinical explanations consistently satisfying. By that autumn, he was living in Lynchburg, Virginia, where he had taken a position that brought him somewhat south and west of the Boston institutions that had defined his career's middle years. He was married to Holly Alexander, and their life in Lynchburg had the quality of a life that had found its settled contours, the rhythms of a household, the particular geography of a city that is neither large nor small, the ordinary texture of days organized around work and family, and the routines that accumulate around any home occupied for long enough. Their sons were at the ages where the house was still fully inhabited by them, still a place organized partly around the schedules of people who were growing into their own lives, but had not yet stepped entirely into them. And there was something else happening in that autumn, something quieter and more personal than the career he was sustaining, running alongside the clinical appointments and the surgical work in the background of his daily attention. Eben Alexander had been adopted as an infant. He had grown up knowing this and had lived the decades of his adult life with the particular relationship to biological origin that adoption can produce, a knowledge of the fact of biological family without any knowledge of the family itself. a gap that for some adoptees is simply a given of their history, and for others becomes a question that eventually requires some kind of answer. For Alexander, the question had eventually moved toward an answer. In the months before November 2008, he had begun making contact with his biological family, the people whose genetics he shared and whose existence had been, until recently, known to him only as an abstraction. The process of that contact had produced something concrete. A photograph had arrived, sent by members of his newly found biological family, representing the first time he had ever seen the faces of people to whom he was genetically related. The specific occasion of receiving that photograph, the specific quality of looking at a face that was simultaneously a stranger's face and something else. This was the kind of moment that doesn't fully resolve on the day it happens. It settles into a person gradually, the way significant things do, finding its place in the story of a life without yet knowing exactly where that place will be. The envelope containing the photograph was somewhere in the house in Lynchburg that autumn. The career at the operating microscope, the lecture halls with their projected diagrams, the careful clinical explanations carried away from patients' bedsides, all of this was also still present, intact, organized, proceeding. A neurosurgeon with decades of practice behind him, and the working assumption, held in the quiet and entirely reasonable way that a life's worth of evidence supports, that the brain generates consciousness, and that its disruptions are legible, and its mysteries are at bottom, the mysteries of a very complex machine whose workings have not yet been entirely mapped. The autumn moved through its weeks with the ordinary, unhurried quality that seasons have, in a city that is not paying particular attention to them. The leaves came down from the trees along the streets of Lynchburg in the early November way. Not all at once, but gradually, the color leaving the branches in a process that is too slow to watch directly and too obvious, when noticed, to have been imperceptible. Alexander was practicing medicine and living in a house where an envelope with a photograph had lately arrived, and the two facts occupied entirely different registers of his attention. The medicine was the foreground. The photograph was something more personal, sitting in a different compartment of the life, still being processed in whatever way newly received photographs of people who turn out to be family are processed. The surgical atlases on the office shelves, the neocortex diagram projected against the lecture hall screen in the low light while the first-year students moved their pens, the patients in their Boston hospital beds, working to describe what they had seen from above the operating table, while Alexander sat at the bedside and listened with genuine attention and clinical conclusions already forming quietly in the back of his mind. The parking lot through the faculty office window in the early evening light. These were the constituent elements of the professional world he occupied, a world organized around a specific and carefully developed model of how consciousness works and what its disruptions mean. There is something worth attending to in the particular position a neurosurgeon occupies in relation to questions about the mind. A position different from that of a philosopher or a theoretical physicist or a theologian, in that it is grounded in direct, repeated, physical contact with the material it is about. Alexander had not arrived at his views about the brain and consciousness through armchair reasoning or through the reading of other people's accounts. He had arrived there through the specific education of hands-on surgical practice across decades, through the kind of knowledge that is built from the cumulative weight of many cases in which the predictions of the anatomical model were confirmed by the observable outcomes of anatomical intervention. When he said, at a patient's bedside, that the vivid experience the patient had reported during their cardiac arrest was consistent with the effects of hypoxia and disinhibited neural firing, He said it from within a framework that his own professional experience had repeatedly and specifically supported. This was not a man who had never looked carefully at the question. The question had arrived on his ward many times, in many patients' mouths, over many years. The answer he had carried away each time was the same answer, and the same answer confirmed by the same clinical logic, and the confirmation had accumulated across the years into something that had the quality of settled ground. The framework was not fragile. It rested on an enormous weight of accumulated clinical and experimental evidence, on the consensus of a field that had built its understanding carefully across generations of careful work. And in the house in Lynchburg, in the autumn of 2008, a photograph was somewhere. The envelope had been opened, the image had been held, the face of someone genetically related to him for the first time, made visible, his biological family, people whose existence had been a fact he knew without knowing them, whose features he had never seen, had recently become, in some beginning way, people rather than an abstraction. The photograph was a physical object, printed on paper, with a particular quality of light in its captured moment, and particular faces looking out of it. It was somewhere in the house, in a drawer perhaps, or on a surface somewhere, or still in the envelope it had arrived in. It was a small thing in the physical sense, and a large thing in the personal one, and November was coming in through the windows of Lynchburg, the way November comes everywhere, with the specific quality of light that belongs to a season that is already shortening the days, the afternoons going gold, and then going dark earlier each time they arrive. The career was intact, the framework was intact, the professional world in which brain function and consciousness were understood to be, at their foundations, the same thing, the world in which a coma is a condition of the brain, and what a person experiences in a coma is a condition of the brain, and the accounts patients bring back from the far side of unconsciousness are products of the brain under extreme stress. This world was intact and occupied and held with the settled confidence of many years of evidence pointing consistently in the same direction. The photograph was somewhere in the house in Lynchburg. The November light was doing what November light does in Virginia, falling at its low angle across the trees, in the streets, and the houses along the roads that wind through that city's particular geography. Alexander was living his life in the ordinary way that a life is lived when it has found its shape and settled into it. The work, the house, the family, the quiet personal matter of the photograph on some surface or in some drawer, the days moving through their autumn sequence without particular announcement. The question of what experience is and where it lives, and whether the 3-pound structure inside the skull is its complete account or only its address. This question was present in his professional life, the way an answered question is present, which is to say, it was settled, filed, and not generating new inquiry. The patients had described their floating, and their lights, and their feeling of arrival in a vast and loving space. And Alexander had listened carefully each time and composed the clinical explanation quietly in his mind each time, and the explanation had been adequate each time. There was no pending case, no unresolved file, no open question that the clinical framework had failed to close. Outside the house in Lynchburg, delight was the particular quality of a Virginia autumn in its final weeks before the cold properly arrived, the last of the leaves still on some of the trees, the afternoons shorter than they had been, the particular coolness that settles into the evenings of early November, carrying in it the straightforward announcement of what is coming. The world was proceeding in the ordinary way. The career was proceeding in the ordinary way. The recently begun, and still unfolding process of contact with his biological family was proceeding in the quiet, gradual way of things that take time to become real, still early in its becoming, still more envelope and photograph than relationship, still a thing being looked at from a certain careful distance before being fully approached, and the photograph was still somewhere in the house. The face in it, not yet anything other than a face in a photograph, belonging to a person whose name Alexander now knew, and whose relation to him he now understood, but whom he had never met, whose voice he had never heard, whose presence in a room he had never been in. A beginning, an opening into something that had been closed. A small rectangle of paper holding a face that was, in some biological sense he was still absorbing, the face of someone who had always existed in his history without his knowledge. The morning of November 10th, 2008 was still a few days away, its particular quality of darkness before dawn not yet arrived, its events not yet set in motion. The house in Lynchburg was quiet, in the way that houses are quiet on ordinary October evenings, the lights in the windows doing what lights in windows do in the autumn, warm against the darkening outside, present, domestic, unhurried, a neurosurgeon's house. A house with bookshelves and a kitchen table, and rooms where the ordinary life of a family organized itself around the routines that families develop without planning them. A house where a photograph had recently arrived in an envelope and been looked at and set somewhere, while the looking continued in the quiet interior way that significant things continue to be looked at after they've been put down. The career behind him was substantial and carefully built. The professional framework he inhabited was coherent and well supported. The life in Lynchburg was the life of a person who had found the shape his days would take and was living them with the particular ease of someone who no longer has to work to locate his place in the world, because the place has long since become familiar. The operating microscope was familiar. The lecture hall diagram of the neocortex was familiar. The bedside conversation with a patient describing what they had seen from above the table was familiar, and so was the clinical explanation that he assembled in his mind while the patient spoke. The photograph in its envelope was newer. The faces in it were newer. The whole dimension of himself that the reconnection with his biological family had opened was newer, not yet settled into the life, the way the surgical atlases on the office shelves were settled, not yet located in its right place, still finding its place. The trees in Lynchburg in late October and early November, the light doing what it does in that season, arriving and departing at the particular angles that belong to that time of year, in that latitude, the mornings a little darker each time they came, the evenings arriving a little earlier, the house quiet, the career intact, the photograph somewhere in a drawer, on a surface, still carrying the face of someone whose name he now knew, whose connection to him he now understood, who was not yet real to him in the full way that people become real when they have been present in a life for long enough. November was still arriving. The days were still ordinary. The question of what consciousness is, and where it lives, and whether the anatomical model that Eben Alexander had taught and practiced and applied across the full length of his career was the complete account or only part of one, this question, which his professional life had given him every reason to consider settled, was still settled. It rested on its accumulated evidence, quiet and undisturbed, the way settled things do, in the weeks before the morning that would give it reason to be reconsidered. In the bedroom of a house in Lynchburg, Virginia, in the early hours of November 10th, 2008, the darkness was still complete. The kind of darkness that belongs to the hours before any light has begun to gather at the edges of the curtains, before the first birds, before the neighborhood has given any sign that another day is beginning. Eben Alexander was asleep, and then he was not asleep, and the difference between those two states arrived with a character he had not encountered before. Not the dull weight of an ordinary headache localized behind the eyes or at the base of the skull, but something else, a pain that seemed to occupy the interior of the head with a totality that left no part of the experience untouched. He sat up. He pressed both hands against his head. The room was dark and still, and the pain was already severe. This is what physicians later described in language consistent with a thunderclap presentation, the term used in clinical neurology for the sudden maximal intensity headache that arrives without warning and reaches its peak within seconds rather than minutes. A presentation that carries specific diagnostic weight because it is one of the classical warning signs of bacterial meningitis and subarachnoid hemorrhage, two conditions that share the feature of being medical emergencies in their earliest detectable moments. The pain Alexander experienced in that bedroom in the early morning hours was not building toward a peak. It arrived at something close to its worst and remained there. The room was dark. The pain did not subside. Back pain followed. Then nausea, the kind that is not entirely digestive in character, but seems to spread from somewhere central, connected to the neurological event, rather than to anything in the stomach. Then light sensitivity, the small amount of ambient light that exists even in a dark room. The faint suggestion of illumination at the window's edge, becoming something that needed to be moved away from. These features, taken together in the sequence in which they arrived, are recorded in the medical literature as a constellation of signs consistent with acute bacterial meningitis in an adult, the infection of the meninges, the membranes that surround and protect the brain and spinal cord, which when inflamed press inward against the structures they are meant to shield. The body registers this inflammation with a specificity that distinguishes it from almost every other kind of head pain, and the body was registering it now, in the dark, in a house in Lynchburg, in the hours before the rest of the city had woken. Holly Alexander would have been there. The house would have been still in the particular way of a family home in the middle of the night, the kind of stillness that shifts when someone in it is in distress. What the morning then required was the recognition that what was happening was not something that would resolve with rest, not something that belonged to the category of discomfort that passes by mourning. It required a decision, and the decision was made, and an ambulance was called. The ambulance that moved through Lynchburg in those early morning hours carried no urgent siren at that time. On those streets, at that hour, the city was quiet. The streets between the Alexander House and Lynchburg General Hospital held the specific emptiness of a southern city before dawn. The traffic lights cycling through their colors for no one, the sidewalks deserted, the storefronts still dark. Inside the ambulance, the overhead lights cast the flat, steady illumination that is particular to medical interiors at night, not the warm light of a home, not the harsh light of a clinical space at full operation, but something between, calibrated to allow work without producing the disorienting brightness that agitates a patient already in distress. Alexander lay in the position that meningitis patients often find most tolerable, the body instinctively seeking whatever configuration reduces the pressure, reduces the light, reduces the demand on a brain that is already under siege from within. Lynchburg General Hospital received him, and the emergency department moved through its initial assessment with the practiced efficiency of a department that handles acute presentations at all hours. The history, the symptoms, the degree of obvious neurological distress, the character of the headache, all of it pointed in a specific direction with enough clarity that the diagnostic workup did not wait. The procedure that would confirm or rule out bacterial meningitis is a lumbar puncture, and the lumbar puncture was ordered and performed. In the procedure, the patient is positioned lying on one side, the knees drawn up toward the chest, the spine curved to open the spaces between the lumbar vertebrae, the lower back exposed and prepared with antiseptic in a small field of clinical sterility. A long, thin needle is then inserted carefully between two lumbar vertebrae and advanced until it enters the subarachnoid space, the fluid-filled gap between two of the meningeal layers, and cerebrospinal fluid begins to flow into the collection tube attached to the needle's end. Cerebrospinal fluid in a healthy person is clear and colorless, resembling water in its appearance. It circulates around the brain and spinal cord, cushioning them, maintaining the pressure environment in which neural tissue operates. When the fluid that collected in Alexander's tube was examined, it was not clear. It was cloudy. The cloudiness that indicates the presence of large numbers of white blood cells, which the immune system had flooded into the cerebrospinal fluid in its response to bacterial invasion. The fluid was visibly abnormal before any laboratory analysis had been completed. The cloudiness alone told the emergency department what it was dealing with, and the treatment that follows a presentation of this kind does not wait for culture results to confirm the specific pathogen. The laboratory culture that would eventually identify the pathogen was already underway. The fluid drawn from Alexander's lumbar puncture was sent to the laboratory with the urgency appropriate to a suspected bacterial meningitis case, and the analysis that followed would confirm the presence of Escherichia coli, a gram-negative bacterium whose name is familiar from food safety contexts, but whose appearance in the cerebrospinal fluid of a previously healthy adult with no identified immune deficiency is something else entirely. E. coli is a rare cause of bacterial meningitis in this population. It is associated far more commonly with neonatal meningitis, with the specific vulnerability of the newborn immune system and the newborn blood-brain barrier, than with infection in a middle-aged adult in otherwise good health. The medical literature documents it, but it is not among the organisms a clinician expects to find when an otherwise healthy adult presents with the classical signs of meningeal infection. It accounts for a small fraction of adult meningitis cases, and its rarity in this context is part of what made Alexander's case unusual even before any other feature of it was known. Alexander was admitted to the intensive care unit at Lynchburg General. The ICU is a particular environment, monitored more closely than any other space in a hospital, its patients attended by more instruments, more frequent checks, more direct nursing observation than is possible anywhere else in the building. The sounds of an ICU are specific and persist through the night, the ventilator cycling with its slow metronomic rhythm, the cardiac monitors tracing their steady green lines across their screens, the infusion pumps keeping their quiet count of fluid delivered per hour. These are the sounds of a room in which the body is being supported by machinery and the work it can no longer fully manage on its own. And Alexander was now in that room, and the machinery was now performing that function. The antibiotic treatment that follows a bacterial meningitis diagnosis is initiated as quickly as possible, often before culture results confirm the specific organism, because the damage the infection produces is related to time, and time is the one resource that cannot be recovered once it is passed. High-dose intravenous antibiotics were begun. Corticosteroids were added to reduce the meningeal inflammation, which is itself a source of neural damage, independent of the bacteria that triggered it. The immune response to infection causes its own injury in the tight enclosed space of the skull, and managing that inflammation is part of managing the disease. Mechanical ventilation supported his breathing, intravenous fluids managed his blood pressure, and the systemic consequences of a severe infection. The treatment protocol that the medical team assembled was the appropriate one for the condition they were treating, and it was implemented with the speed the condition required. The family was in the building. Holly Alexander would have been brought to a waiting room at some point in this process. The kind of waiting room that exists in every hospital but is experienced differently in crisis. The chairs along the wall taking on a different quality. The window showing the parking lot outside in whatever light belonged to the hour. The small table with the outdated magazines becoming the entire geography of the world for however long the waiting continued. This is where family members sit, while the medical team does what the medical team does, while the doors between the waiting room and the treatment areas define the limit of what the family can be present for. The parking lot outside the window was visible in the flat mid-morning light, ordinary and entirely indifferent to what was happening inside the building. The prognosis that the medical team communicated to Alexander's family in those early hours was serious in the direct clinical way that serious prognoses are communicated when the responsible thing to do is to be clear. The infection was severe. The neurological compromise had been rapid. His early response to antibiotic treatment was not encouraging. In cases of bacterial meningitis with this degree of documented cortical involvement, the survival rate is significantly reduced from cases caught earlier or caused by organisms that respond more rapidly to treatment, and survival without meaningful cognitive impairment is rarer still. The family was advised that meaningful recovery, the return of the person they knew, cognitively intact, neurologically functional, was considered very low probability given what the clinical picture showed. This is not a judgment or an error on the part of the physicians who communicated it. It was the honest reading of a clinical situation that the available evidence supported. The EEG monitoring that was in place during this period generated its own record. Electroencephalography maps the electrical activity of the cortex through electrodes placed on the scalp, producing the characteristic trace of oscillating waveforms that represents the brain in its various functional states. The busy, varied activity of a waking mind, the different configurations of sleep, the altered patterns of sedation and anesthesia. In Alexander's case, the EEG trace during the depth of his illness showed dramatically suppressed cortical rhythms, the waveforms quieted to a fraction of their normal amplitude and variability, consistent with the degree of neurological injury the infection had produced, and with the clinical picture the team was observing at the bedside. This paper record, this physical strip of graph paper covered in the flattened, irregular traces of a brain working far below its normal capacity, would become one of the central pieces of evidence that Alexander himself would later cite. The instrument-based confirmation that his neocortex was severely compromised during the period in which he would also report having the most vivid and expansive experience of his life. The Glasgow Coma Scale, the standardized clinical instrument used to assess the depth of unconsciousness, measures 3 domains: eye-opening, verbal response, and motor response, each scored on a scale, with the combined scores ranging from the minimum of 3, no response in any domain, to the maximum of 15, representing a fully conscious and responsive patient. A score of 8 or below is clinically defined as a coma. Alexander's scores during the depth of his illness were documented at or near the lowest end of the scale, indicating the absence of meaningful eye-opening, verbal output, or purposeful motor response. In the clinical literature on bacterial meningitis, scores at this level are associated with very high mortality rates, and the few patients who survive with documented cortical involvement at this severity, frequently sustained permanent neurological deficits. The number entered in blue ink beside the date in Alexander's chart, repeated across successive nursing entries as the days passed, represented not just an assessment, but a forecast, a number that predicted, with the force of accumulated clinical evidence, where this was likely to go. The Escherichia coli, confirmed by laboratory culture in Alexander's cerebrospinal fluid, was a gram-negative organism which carries specific implications for treatment. Gram-negative bacteria have a cell wall structure that includes an outer membrane containing lipopolysaccharide, a component that, when released in large quantities during bacterial death or antibiotic treatment, can trigger a severe inflammatory response. This is part of why the management of gram-negative meningitis requires not just killing the bacteria, but managing the inflammatory cascade that killing them produces. The antibiotic regimen was adjusted once the culture results established which specific organism was present and confirmed its sensitivity profile, the laboratory test that determines which antibiotics the particular strain of bacteria responds to, allowing the treatment to be made as precise as possible, given what the culture had identified. This adjustment takes time. The organism must be grown, its sensitivities tested, the results communicated, the orders changed. All of this is routine medical procedure, calibrated and methodical, and all of it was happening in the background of a situation that was also, at its center, profoundly uncertain. There is a particular quality to the days that follow a family member's admission to an ICU with a poor prognosis. The hospital becomes its own world, with its own rhythms and its own geography. The waiting room, the corridor outside the ICU, the short walk to the cafeteria, the chairs that the body learns to know by the second day. These become the whole of the available landscape. The light from the windows tracks the time in a general way, marking the passage of morning into afternoon, into evening, without the usual punctuation of activity that ordinary days contain. Food appears and is eaten without much attention. Conversations with the nursing staff become familiar. The numbers on the monitors, the frequency of checks, the faces of the physicians who come to deliver updates, all of it accumulates into a kind of knowledge that is not medical knowledge, but is the family's equivalent of it. The pattern reading that happens when the people who love a patient begin to understand, from experience rather than training, what the shifts and comparisons mean. Holly Alexander was in the building, the family was in the building, and Alexander was in the ICU, connected to the machinery that was managing what his body could no longer manage entirely on its own, his chart accumulating daily entries, his Glasgow Coma scale scores persisting at the lower end of the scale as the hours and then the days continued to pass. The identity of the pathogen, E. coli, confirmed by culture, a gram-negative organism, rare in this population, documented in the literature, but not commonly encountered in otherwise healthy adults, presenting through a hospital emergency department, was now a clinical fact. The cloudiness of the cerebrospinal fluid, observed in the collection tube during the lumbar puncture in the early hours of November 10th, had been the first physical confirmation of what the clinical picture suggested. The laboratory had then given the infection its name, its gram classification, its sensitivity profile. The antibiotic regimen had been adjusted accordingly. The monitoring continued. The ventilator continued its cycling. The cardiac monitor continued its green traces across the screen. In the days following admission, as the antibiotics worked against the identified pathogen, and as the medical team assessed Alexander's neurological status at regular intervals, The picture that emerged was one of profound unresponsiveness. Sedation was reduced on multiple occasions, specifically to allow the team to assess what the brain was doing in its own right, independent of the sedating medications that were part of the treatment protocol. On each of those occasions, the assessment returned the same finding: absence of meaningful response. The brain, as the team could observe it through the instruments available and through direct clinical assessment, was not producing the responses that would indicate it was engaged in the usual business of a mind. The question that the clinical record documented, repeatedly and across multiple assessments, was not whether Alexander was deeply unresponsive. The record was clear on that, but whether anything recoverable remained beneath the level of what the instruments in the clinical assessment could detect. This is a question the clinical record cannot fully answer, and it is worth holding that limitation plainly. The instruments available, the EEG, the Glasgow Coma Scale assessments, the clinical observation, are powerful and well-validated tools for measuring what they measure. They measure what is detectable. They measure the brain's electrical output at the cortical level, the presence or absence of behavioral responses to stimulation, the general architecture of physiological function. What they cannot do, by their nature, is establish with certainty the complete state of everything that is happening inside the system they are measuring. This is not a mystical claim. It is a straightforward statement about the limits of any measurement instrument. The clinical record from Alexander's hospitalization documents, with precision and consistency, what the instruments found, what the instruments could not find. They also could not rule out entirely, and this distinction between the absence of a detectable signal and the absence of any signal at all would become one of the most carefully examined aspects of his case in the scientific literature that later engaged with it. The medical team documented what they observed and measured, entered it in the chart, communicated it to the family, and continued the treatment. The treatment was the right treatment for the condition they were treating. The prognosis they communicated was the honest reading of the clinical evidence. The Glasgow Coma Scale scores that appeared in blue ink beside successive dates in Alexander's chart were the accurate recording of what the bedside assessments found. None of this was in error. It was clinical medicine practiced with appropriate care and rigor, applied to a case that was, by the standards of the clinical literature, among the most severe presentations the treating team was likely to encounter. The waiting room at Lynchburg General, during the days that followed Alexander's admission, held the particular, suspended quality of a space in which time has been reorganized around a single fact. Outside the window, the parking lot continued its ordinary existence. Cars arriving, cars leaving, the light moving across the pavement as the day progressed through its hours, in the way it always did. Inside, the chairs along the wall, the small table, the fluorescent light overhead, the periodic appearances of the medical staff with their carefully worded updates. These defined the available world. The Sons were in the building, Holly was in the building, and in the ICU, separated from the waiting room by the corridor and the doors that marked the boundary between the family's world and the clinical world, Alexander lay unresponsive in the monitored stillness of a critical care room, the machinery around him continuing its quiet metronomic work. The cultures that had identified the E. coli pathogen were themselves a document, a small physical record of the organism that had entered the meningeal spaces of a neurosurgeon's brain, one of the most extensively trained and anatomically expert minds in the building in which it was now being treated, and begun the process of damage that the clinical record was tracking day by day. The sensitivity results that had allowed the antibiotic regimen to be adjusted were another document. The EEG traces were another. The Glasgow Coma scale entries, repeated across successive days, were another. Each of these was a physical artifact of what November 10th had begun, a record that could be held, filed, reviewed, and compared against the literature that covered cases of this kind. None of these documents, taken individually or together, resolved the larger question of what the experience of being in that state might or might not include. They described the brain's measurable outputs and its measurable responses to external stimulation. They did not describe, because instruments of this kind are not designed to describe, what it is like to be inside the system they measure. This is not an opening for any particular interpretation. It is simply an honest statement of what the clinical record contains and what it does not contain. And the clinical record from Lynchburg General Hospital is in this respect entirely consistent with clinical records from every other case of severe neurological compromise in the literature, detailed, careful, and bounded by the inherent limits of external measurement. The morning of November 10th, 2008, had produced a set of findings that were now entered into the medical record at Lynchburg General Hospital. The cerebrospinal fluid drawn during the lumbar puncture, cloudy, abnormal, carrying the bacterial presence that the laboratory had now confirmed and identified, was the first physical evidence that what Alexander was experiencing was not something that would pass by mourning. It was the evidence that placed him in a category of patients for whom the clinical literature held a specific and sobering prognosis, and it was the evidence that initiated the treatment protocol and the monitoring and the family vigil in the waiting room and the daily Glasgow Coma scale assessments and the EEG traces and the blue ink entries beside the successive dates in the chart. The fluid had been cloudy. The laboratory had confirmed the pathogen. The chart had been opened. The entries had begun. The machines had been connected, and the treatment had commenced. All of it was documented, recorded, preserved in the physical records that remained in the Lynchburg General Hospital record system. The admission date, the laboratory results, the EEG data, the daily assessments. The diagnosis had been made, and it had been made with the precision that the tools available to the clinical team permitted, and the precision was considerable, and what it had produced was a clinical record of a brain under severe infectious assault, a body maintained by medical intervention, and a family in a waiting room with a view of a parking lot outside, in the flat, ordinary light of a Virginia November. That the fluid had been cloudy was the simplest and most durable fact of what November 10th had produced. The laboratory culture had given the cloudiness its name. The name was on the chart. The chart was in the records. And whatever was happening inside the system that the chart described, whatever the monitored, unresponsive brain of Eben Alexander was, or was not doing, in the hours and days that followed his admission to Lynchburg General, the cloudiness of that fluid, confirmed and documented and filed, was where the record began. The ICU room at Lynchburg General Hospital in the early hours of November 11, 2008, held the particular quality of stillness that belongs only to critical care units after midnight. Not silence exactly, but a steady, layered sound that becomes its own kind of quiet. The mechanical ventilator beside the bed cycled with a slow, metronomic pull and release, the same interval repeating without variation in the low light. The cardiac monitor traced its green waveforms across the screen in an unbroken line, the signal of a heart still working, still producing its regular mark on the display, the shape of it familiar and calm in the way that machines in continuous operation are calm. Alexander lay motionless in the bed, his breathing managed entirely by the ventilator, his face still, his hands at rest on the blanket in the half-dark of the room, The nursing staff moved through their rounds at their practiced intervals. The 4 lines running from the pole beside the bed carried fluid through transparent tubing that caught the low ambient light of the monitors and threw it back in a faint, moving shine. There were 2 bags of antibiotic solution hanging from the pole, the treatment already begun before the pathogen had been fully identified, the bacterial culture still processing in the laboratory, the doses adjusted as results came through. A nurse documented her observations in the chart at the bedside, the time, the ventilator settings, the blood pressure reading from the arterial line, the brief notation of neurological status, and moved to the next room. The room received her departure without registering it. The ventilator continued its rhythm. Alexander had been unresponsive since his admission. The clinical term for what the team was managing was bacterial meningitis, with documented cortical involvement, a severe, rapidly progressing infection in which the E. coli pathogen, having crossed into the central nervous system through mechanisms not fully determined, in his case, had triggered an inflammatory response across the meninges. The meninges are the 3-layered membranes that encase the brain and spinal cord. In severe bacterial meningitis, their inflammation produces what the clinical literature describes as a cascade of injury, rising intracranial pressure, compromised blood flow to cortical tissue, direct cellular damage from the immune response, as much as from the bacteria themselves. The neocortex, the folded outer layer of the brain, where higher-order cognitive processing is understood to occur, was at the center of that process. Physicians had administered corticosteroids alongside the antibiotics. The corticosteroids were intended to reduce the meningeal inflammation directly, to interrupt the cascade before it progressed further, to buy time for the antibiotics to work. The treatment protocol was standard for severe bacterial meningitis, with the documented characteristics of this case. It was the correct treatment. The question that would not be answered for several more days was whether it had been begun early enough, and whether the brain it was working to protect retained enough undamaged tissue to support recovery. Those questions remained open in the first hours of November 11th. They would remain open for days after that. The EEG equipment had been connected to Alexander during the first day of his admission. Electroencephalography places a series of small electrodes at standardized positions across the scalp, attached with conductive gel, held in place by a cap or individually adhered, and records the electrical activity generated by the neurons of the underlying cortex. In a normally functioning brain, the EEG traces a pattern of active, oscillating waveforms, the rhythms of different frequencies that characterize waking cognition, lighter sleep, deeper sleep, the various states of a brain in continuous operation. The paper printout of Alexander's recording was different from those active traces in a way that was clinically significant. The waveforms were suppressed, the oscillatory complexity that characterizes normal cortical activity was reduced. The traces were not flat in the sense of an absence of all signal that would have been a different finding entirely, but they were dramatically quieter than the baselines a healthy brain produces, consistent with the degree of neurological injury the infection had caused, and with the clinical findings recorded in the chart alongside them. That printout would become one of the central pieces of documentation Alexander would later cite when discussing his case. A long strip of graph paper, the traces printed across it in the narrow, compressed form that EEG recordings take, a visual record of the brain's electrical state during the period of his coma. What it showed, in clinical terms, was a brain under extreme physiological stress, its higher-order electrical rhythms substantially suppressed by infection and inflammation. What it did not show, and what the technology is not designed to detect, was the presence or absence of every possible form of neural activity at every possible level of the brain's organization. Those distinctions would matter later, and the people who would argue them from different directions would both refer to the same printout. But in the first hours after admission, the printout was simply a piece of clinical documentation, one entry in a growing record, its lines tracing their quiet, dampened path across the paper in the records of a severely ill patient. The medical team had communicated to Alexander's family during the first day that his prognosis was grave. This communication had been honest and specific. They had not withheld the severity of what the admission findings showed. The cerebrospinal fluid, drawn during the lumbar puncture the previous day, had been cloudy, visibly abnormal, rather than the clear fluid it should have been, its turbidity caused by the bacterial burden, and the white cell count, both dramatically elevated. The bacterial culture had confirmed E. coli. The sensitivity profile had been established from the culture, and the antibiotic doses had been adjusted to match it. All of that had happened quickly, competently, and according to the established protocols for managing bacterial meningitis, and Alexander remained unresponsive through all of it, his neurological status unchanged each time the team assessed him. Holly Alexander was in the hospital. She had been there since the admission, moving between the ICU and the waiting areas, with the particular pattern of movement that family members develop across long vigils, a geography of the building that becomes familiar very quickly. The paths between the places where information arrives and the places where the hours are spent. The chairs in the family waiting room along one corridor were arranged against the wall, low and upholstered in the muted colors that waiting areas tend to use, as though the softness of the palette might ease something. A window in the room looked out over the hospital parking lot. The light that came through it changed across the hours of the day, from the flat gray of early morning through the stronger white of midday and back toward the amber of late afternoon, and this changing light was one of the ways the hours could be marked when there was otherwise nothing to distinguish them. Her sons were with her for much of the time. Eben Alexander IV, then a teenager, was a near constant presence across the 7 days. The vigil was not organized around scheduled visiting hours in the way that some hospital stays are. The severity of the case and the family's proximity to the ICU meant a more continuous kind of attendance, the sort that develops when the medical team is delivering information at irregular intervals and the family finds itself staying near the point where that information arrives. Across several days, there were conversations with physicians in which the prognosis was revisited. Meaningful recovery was considered very unlikely. The percentage attached to the possibility of survival with any retained cognitive function was low. The medical literature on severe bacterial meningitis with documented neocortical involvement does not produce optimistic numbers, and the team was not in a position to offer numbers. It did not have. The conversations were honest. They were also difficult in the way that conversations of that kind are always difficult, regardless of how carefully and clearly they are delivered. At several points across the 7 days, the medical team reduced Alexander's sedation to assess his neurological status directly. This is a standard component of ICU management for comatose patients. The periodic reduction of sedating medications to establish whether the observed unresponsiveness reflects the depth of chemical sedation or whether it persists independently of that sedation. On each occasion that the sedation was lightened, Alexander remained unresponsive. He did not open his eyes. He did not make sounds. He did not produce purposeful movement in response to stimulation. The Glasgow Coma Scale the standardized clinical tool used to quantify the degree of impaired consciousness in patients with neurological injuries, assigns points across 3 domains: eye-opening, verbal response, and motor response. A fully responsive person scores 15. The lowest possible score is 3. Alexander's scores, as documented in the chart entries made across those days, registered at or near the bottom of the scale during the depths of the coma, values that the clinical literature associates with the most severe neurological impairment and with the poorest statistical outcomes in cases of infectious meningitis with cortical involvement. The nursing staff rotated through their shifts. The day shift arrived, and the night shift departed, and the day shift departed, and the night shift arrived again, and this pattern repeated across the days, while the figure in the bed remained the same, motionless, ventilator supported, his neurological status unchanged on each assessment. The monitor traces continuing their steady work across the screen. The antibiotic infusions ran through their cycles and were replaced. The fluid management was adjusted to the values recorded in the daily lab work. The corticosteroids continued. The care was meticulous and continuous. The infection it was treating was severe. There is a particular quality to the passage of time in a hospital room where a patient is in a sustained coma. The room does not change. The light changes. The window may show the shift from night to day. The overhead fluorescent panels are adjusted for the time of day. The quality of illumination in the corridor outside the glass panel in the door shifts across the hours. But the room itself is constant. The ventilator cycles. The monitor traces its lines. The 4 bags drain and are replaced. The nursing entries in the chart accumulate. The dates on those entries are the clearest record that time is passing, that 1 day has become 2 days, that 2 days have become 4. From outside the room, the accumulation of those dates is visible. From inside the room, in the ordinary sense in which someone in the room might experience it, nothing could be said about time at all. On the second full day of the coma, November 12th, the clinical picture had not changed in the direction that would have indicated the treatment was gaining ground. The infection was severe enough, and the inflammatory response to it was significant enough that the early days offered no clear signal of which direction the case would move. The team continued. The family continued their vigil. The chart continued to receive its entries. The EEG monitoring continued to produce its traces. In the early days of the coma, the primary clinical concern was not only whether Alexander would survive, but what the specific pattern of neurological damage would look like if he did, which functions would be intact, which would be compromised, what the bacterial invasion and its resulting inflammation had affected, and in what degree. These were not questions that could be answered while the infection was still active. They were questions for a recovery that the team did not yet know would occur. By the 3rd and 4th days, there were physicians who raised with the family the question of what Alexander himself would have wanted, and what the family's wishes were regarding the continuation of life support in the event that the current trajectory continued. These conversations are a standard component of care when a patient's prognosis is as severe as the documented findings indicated, and they were handled with the directness and care that the situation required. Holly Alexander later described these conversations in public accounts as among the most difficult moments of the vigil. Her son remained at the hospital through much of this period, in the corridor outside the ICU, at various hours of the day and evening, present in the way that people are present, who have no other place they feel they should be. The corridor outside the ICU at Lynchburg General Hospital in November 2008 would have had the particular character of hospital corridors during the evening portion of the facility's cycle, The overhead lights adjusted to a slightly lower level than during peak daytime hours. The traffic of staff and visitors reduced. The sounds of the facility settling into the quieter but continuous pattern of a building that never fully stops. A teenager sitting in a chair along the wall in that corridor, his hands resting on his knees, the hours of the evening moving past. This is a specific kind of waiting that belongs to a specific kind of experience. It does not have a scale. The Glasgow Coma scale is a number. This is not a number. It is simply the fact of the corridor, and the chair, and the hours moving, and the door to the room where the ventilator is still cycling, and the monitor is still tracing its green lines across the screen in the low light. The 5th and 6th days brought no dramatic change in the clinical picture, though the infectious process appeared to be responding incrementally to the antibiotic regimen. The laboratory values were being tracked at intervals, and the trend in some of the inflammatory markers was beginning to suggest that the bacterial burden was being reduced. This was not by itself a clear signal of neurological recovery. The damage to the cortical tissue that the infection had caused was not something that antibiotic treatment would reverse. Antibiotics address the pathogen. The damage the pathogen has produced is a separate question. The team was managing both dimensions simultaneously, working to eliminate the bacterial cause while also monitoring the neurological consequences, which would only become fully visible when or if the patient moved out of the comatose state. On the morning of November 17, 2008, the 7th day after his admission, the medical team documented the first signs that Alexander was beginning to respond. The clinical record of this moment, the specific entries made in the chart, the observations noted by the nursing staff and the attending physicians, reflects the careful language of people trained to avoid overstating what they see. The initial responsiveness was not a sudden awakening of the kind that dramatic accounts sometimes describe. It was smaller than that. Eye movement, a response to stimulation that had not been present on the previous assessment, a shift in the pattern of behavior that fell within the lower range of responsiveness on the Glasgow Coma scale, but was nonetheless a shift, a distinction between what the assessments had shown for the previous 6 days and what they showed now. The team noted it. The chart recorded it. The monitors continued their work. Holly Alexander was informed that her husband was beginning to show signs of responsiveness. The nature of this communication would have been careful and precise. The team was experienced enough to frame an early neurological signal accurately, without overpromising, without understating. Something was changing. The direction of the change was not yet fully determined. The quality of any recovery that might follow could not yet be assessed, but the pattern that had held unchanged across 6 full days had shifted on the morning of the 7th, and that shift was documented and communicated. What comes after an awakening from a coma of this severity and this duration is not simple. The brain that has been under that degree of infectious and inflammatory assault does not resume its ordinary function immediately or predictably. The recovery of consciousness is often gradual, fragmented, and inconsistent, cognition returning in pieces, language following a trajectory of its own, memory operating according to a timeline that cannot be predicted from the severity of the insult alone. The medical literature on meningitis survivors with documented cortical involvement notes a wide range of outcomes, and Alexander's was considered, by the standards of what his admission findings had suggested, a recovery that the clinical team had not projected, not because it defied mechanism. Bodies do recover from severe illness, and the capacity of the brain for plasticity and reorganization is itself a documented phenomenon. But because the specific combination of severity, duration, and documented neurological compromise that his case presented had placed him statistically in a group for which meaningful recovery was considered very unlikely. The chart at Lynchburg General continued to receive its entries in the days that followed November 17th. The dates accumulated. The ventilator was weaned. The monitoring continued. The Glasgow Coma Scale scores began, incrementally, to move upward from the bottom of their range. The nursing staff documented each change in the way they had documented everything before it, carefully, precisely, in the specific language of clinical observation that neither inflates nor diminishes. The case file that accumulated in the record system during those weeks was dense with this kind of documentation: the admission date, the laboratory values, the EEG traces, the GCS scores across the days, the antibiotic records, the discharge summary that would eventually close the acute phase of the record. There was something in the room with the ventilator and the monitor and the 4-pole in the quiet hours of the night shift that the chart could not record. And this is not a mystical claim, but a simple fact about what documentation is for and what it cannot reach. The chart records what can be observed and measured from the outside of a patient: the vital signs, the clinical scale scores, the laboratory results, the radiological findings, the nursing observations. It does not record what the interior of the patient's experience was during the period those observations were being made, because that interior is not accessible to the instruments doing the recording. This is true of all comatose patients, not only of Alexander. What was happening, if anything was happening, in the subjective dimension of his experience during those 7 days is a question the chart does not answer. It was not built to answer it. The chart answers the questions it can answer, and the questions it cannot answer remain in a different register entirely. The family's vigil continued through November 17th and into the days that followed the first signs of responsiveness. The waiting room had been a part of their geography for a week. The particular window that showed the parking lot outside in flat mid-morning light had been there each morning. The corridor outside the ICU had received the hours of the day and the evening hours and the night, with its dimmed lights and reduced traffic, and then the morning again, 7 times before the chart recorded the first change. The accumulation of those hours is not something that can be summarized without losing what it actually is: the specific texture of a long vigil, the particular quality of attention that is sustained, not because there is anything to do with it, but because putting it down does not feel possible. By the time Alexander was beginning to show more consistent signs of awareness, in the days after November 17th, the clinical team had begun the process of assessing what the recovery would look like, which cognitive functions were intact, which had been affected, what the longer-term trajectory of his neurological status might be. This was a process that would continue well beyond the acute phase of his hospitalization. The brain that had been the subject of the EEG monitoring and the Glasgow Coma Scale entries across 7 days was now in the process of revealing what the infection had left intact and what it had damaged, and this revelation was gradual, and its eventual character was something no one in the hospital in November 2008 could have predicted from what the chart contained at that point. The ventilator in the room had cycled through its rhythm for the better part of a week by the time the morning of November 17th arrived. Its sound, the slow pull and release, the metronomic interval that had been the constant bass note of the room through the day shifts and the night shifts and the quiet hours of early morning, was still present when the first signs of responsiveness were noted and documented. The monitor was still tracing its waveforms. The 4 lines were still running. The room itself had not changed. What had changed was something in the patient, something that the clinical tools could now begin to detect from the outside. the early cautious signal of a brain resuming its capacity to respond to the world that had been waiting for it, visible to observation, now in the way that it had not been for 6 days before. The morning of November 17th, 2008, was the 7th day of the vigil and the 7th day of the coma's depth, and the medical team's documentation of the first observed change in Alexander's neurological status was the specific, careful record of something his physicians had not expected to have to record. They had managed the case with full clinical effort throughout. The treatment had been appropriate, the monitoring had been continuous, the communication with the family had been honest and thorough, but the clinical framing that had accompanied those communications had been a framing of very low probability. The chart entry that noted the first responsiveness was, in that sense, an entry that fell outside the projected range of what the case had been expected to produce. It did not explain itself. It simply noted what was observed in the careful, neutral language of clinical documentation and stood beside the other entries in the record as one more fact in a file that had been accumulating for a week. The green waveforms on the cardiac monitor continued their trace across the screen in the low light of the ICU room. The ventilator continued its rhythm. The 4-line continued its slow movement through the tubing. And somewhere in the body of the man in the bed, something that had been entirely still for 7 days had begun, in the smallest and most carefully documented of ways, to move. In the days immediately after November 17th, 2008, Eben Alexander sat at a desk somewhere in his house and opened a notebook. His handwriting, by his own account, was not quite what it had been before, the neurological recovery still underway. The hand not yet fully reliable, and the effort of setting down the details of what he had experienced was visible in the way each word arrived slowly and with some deliberation. He was not writing a book at this point. He was not composing an argument. He was doing what any careful observer does when they know that memory degrades at the edges first. He was recording what he could while it was still present in something close to its original form, before ordinary life and ordinary forgetting could work on it from the outside. This act of recording is documented. The notebook exists. The timing, the effort to transcribe before the details dissolved, is consistent with what Alexander has described in subsequent interviews and in the book he eventually published in 2012. And what that early notebook contained, what he was working to hold in place with his slightly unsteady hand, was an account that bore very little resemblance to the structured sequential narrative most people carry when they try to describe a dream or a memory. What he described was not a story with a beginning and a middle and a recognizable logic. It was something closer to a set of overwhelming qualities, textures of experience that he later said no available language quite matched, rendered into words at the desk, only because words were the only instrument he had. The account he eventually gave, in lectures and in print, begins in a place of darkness, not the darkness of sleep, not the featureless black behind closed eyes, something more textured than that, more present. Alexander described the first environment he was aware of as subterranean in quality, low and dense, filled with a kind of churning noise he found difficult to characterize precisely, except to say it was rhythmic and not pleasant. He later called this the earthworm's eye view, a phrase that captured something of what he meant, a perspective from far below, a vantage without height or clarity, surrounded by material that pressed in from all sides. Roots, he said, or something like roots, mud, a dimness that was not empty but full of something moving slowly and without apparent purpose. What he described as particularly striking about this first realm was not its discomfort, but its anonymity. In the earthworm's eye view, as he has consistently described it, There was no sense of being Eben Alexander. There was no biography present, no memory of Lynchburg, no memory of surgery, no memory of a house or a family or a name. The self that lay in the bed at Lynchburg General under the mechanical ventilator was not in attendance. What was present was awareness without a label for itself, experience without a prior context to hang it on. Alexander later argued that this quality, the absence of any recognizable personal content, any memory or imaginative material he could have drawn from his own stored experience, was part of what made it difficult to account for the experience as a product of his own dreaming or unconscious mind. A dreaming brain, he noted, draws from the material it has been given. The earthworm's eye view contained nothing he could have drawn from anywhere. This is reported as he has given it. It is personal testimony. The experience, as it has been set down, describes these things with great consistency across years of telling and across different formats and audiences. A consistency that is itself one of the details that researchers studying NDE reports have noted as characteristic of the phenomenon across many separate cases. Whether that consistency reflects the permanence of something genuinely encountered, or the way memory consolidates and stabilizes a narrative over repeated tellings, is not a question the notebook can answer. Both are possible. The notebook holds what he wrote while the handwriting was still slightly unsteady, and what he wrote was darkness, density, churning sound, and no sense of self. At some point in the account, Alexander has been careful to say that the experience had no obvious clock running alongside it, no sequential time in the ordinary sense. Something changed. He described a point of light, and not a light that appeared at a distance and then grew closer, but something that arrived in a different way, a spinning brightness, white and concentrated, that he experienced less as a visual event than as an opening. He called this the gateway, a threshold rather than a place, an edge that in crossing changed the quality of everything on the other side in a way that was immediate and complete. The spinning was accompanied by a sound, and here Alexander's descriptions have remained consistent across many retellings, something he has compared to an immense resonant choral tone, not heard in the ordinary sense, but received in a way that bypassed the category of hearing entirely. It arrived, he has said, all at once, without sequential build, the way a chord contains all its notes simultaneously, rather than unfolding them, one after another. The gateway, as Alexander has described it, was not a resting place. It was transitional. What was on the other side of it was something he has struggled more with naming, and the name he eventually settled on, the core, reflects that difficulty, being a spatial metaphor for something that was not experienced as having spatial properties in any familiar sense. The core, as he has consistently described it, was dark in the sense that it was not visually defined. There was no landscape, no architecture, no light falling from a source onto a surface, and yet the darkness was not empty. It was, he has said, the most full and complete state of awareness he has ever been in, before or since. A paradox that he has noted himself, describing it in the language available to him, that the absence of visual content was accompanied by a sense of presence so total and so intimate that the word presence barely contains it. In the core, Alexander has said, there was knowledge, not the sequential accumulation of information, not the experience of learning, of moving from not knowing to knowing, but something he has called instantaneous knowing, complete packages of understanding that arrived without the sentence structure that normally carries understanding along. The mode of delivery, as he has described it, was more like being shown something all at once than like being told it, and what arrived in this way was not primarily information in the factual sense, not names, not dates, not propositions, but something he has compared to the emotional understanding one carries after a long and close relationship, the kind of knowing that is not made of words and cannot be fully put into words after the fact. When he came to write it down in the notebook, this was the part that proved most resistant to the page. What was communicated to him in the core, and he has used the word communicated because it was not passive, it was not ambient, it was addressed in a way that felt specific, included, he has said, something about the nature of consciousness, about love as a condition of the universe rather than a product of biological evolution, and about the relationship between the individual self and something vastly larger than any individual self. These are large claims, and Alexander has not retreated from them, though he has also been consistent in noting that the language available on the other side of the experience is not adequate to the content it is trying to carry. He comes back again and again in lectures and in interviews to the same point, that the experience, as he returned from it and moved further from it in calendar time, did not become more doubtful to him, but more certain, and that this was itself an unusual property, given that most experiential memories, including vivid ones, become less rather than more vivid over time. The third element of the account, and the one that has attracted the most sustained and specific attention from people examining his case, involves a figure. Not a figure in the sense of the vast, unlocatable presence he described in the core, but a specific person, a young woman. Alexander has described her as appearing in the transitional period between realms, riding on the wing of a butterfly, amid what he described as a landscape of extraordinary color and richness, a natural environment, flowering and wide, at an altitude that he could not measure but felt was above ordinary ground. She was dark-haired, he has said, with high cheekbones, and a particular quality to her expression that he experienced as simultaneously communicating several things at once, welcome and recognition, and something that he has translated as the knowledge that he was loved and safe, and that there was no possibility of harm. He did not know who she was. During the experience itself, this was not a question he held. The experience had no room for the particular kind of puzzlement that comes from seeing a face and reaching in the memory for a name. There was simply the face and the quality of presence she carried, and the wing of the butterfly spread beneath them both as a wide surface of color in a landscape that he has described consistently as more vivid than any waking perception he had retained from his 40 years of ordinary life before November 2008. When he came back, when the neurological machinery of his body resumed sufficient function to return him to the world of rooms and light and other people, he did not know who she was. This is the part of the account that holds the longest and most careful attention when it is examined in detail, because what happened after his return was specific enough to be traced. Alexander had been adopted as an infant. He had spent his adult life knowing, in the abstract, that biological family existed somewhere outside the life he had lived. And in the months before his illness, he had made contact with that biological family for the first time. Letters had been exchanged, photographs had been shared, but the sequence of events had not reached completion before November 10th, 2008, and the envelope with the photograph of his biological sister Betsy had arrived in his house before the illness, but had not yet made its full impression on him, had not yet turned a name into a face that his memory had time to hold. After his recovery, the biological family sent a photograph. The accounts of what happened when Alexander saw it have been consistent from the first telling. He recognized her. not with the gradual, uncertain recognition of a face that looks familiar and requires time to place, but with something immediate, a recognition that arrived before he had time to construct it, before the questioning mind could get ahead of the response. The woman in the photograph was Betsy, his biological sister, who had died before Alexander had ever met her, who had been a stranger to him in every verifiable biographical sense, and she was, he has said, the woman on the wing of the butterfly. This detail is the hinge of the account. It is the point where the experience, which might otherwise be held at the distance of an unusual but internally private event, reaches out and touches something in the verifiable world, a specific person, a specific photograph, a specific moment of recognition. It is also, of course, the point where the account becomes most difficult to evaluate. The recognition is real to Alexander. He has described it in the same terms across many years in many different contexts, always with the same quality of certainty and the same quality of weight. Whether the woman in the experience and the woman in the photograph are connected in the way Alexander believes, whether the connection is anything more than the mind's tendency to find, in a face it finally encounters, the outlines of a face it has been holding without knowing it, is not a question that can be answered by the evidence alone. The recognition happened. The sister was dead before he met her. The photograph arrived after the coma and not before. These are the facts that can be checked. What they mean sits further back, in a place the facts do not quite reach. In his 2012 book, Alexander described the moment of seeing the photograph as a form of completion, the closing of a loop that he had not known was open. He had returned from the experience carrying a face he could not name, and the world had then presented him with a name for the face. He has described this repeatedly, not as the part of the account that proved everything else, but as the part that grounded it, the concrete detail that prevented the experience from remaining entirely internal and unverifiable. And he has been careful, in most contexts, to hold the distinction between what can be established and what can only be reported. The recognition is reported. The feeling of it is his. What it confirms about the nature of what he experienced in the coma is not something he can demonstrate to the satisfaction of someone who was not there, and he has acknowledged this in recorded conversations with skeptics and researchers alike, while also making clear that the acknowledgement does not diminish his certainty. The quality of certainty he describes is itself one of the features that places Alexander's account within a broader documented pattern across the near-death experience literature, across the prospective studies and the case collections and the interview archives accumulated by researchers over the last several decades. One of the features reported most consistently by people who describe these experiences is exactly this, that the certainty does not erode. Ordinary memories soften at the edges. Dreams, even vivid ones, become difficult to hold in their original form as hours and then days pass. What NDE experiencers report, with a frequency that researchers including Pim van Lommel have documented and noted in published work, is the opposite, that the experience becomes more vivid over time rather than less, more certain and not less, and that the years between the event and the present moment do not carry the usual erosive quality. Alexander's account fits this pattern precisely. He has said, in interviews recorded across the decade following his recovery, that his certainty about what he experienced is now greater than it was in the early days at the desk with the notebook, not because he has accumulated arguments in its favor, but because the quality of the experience has not diminished the way every other memory he holds has diminished. The account he has given in lectures carries a specific quality of texture that is worth following in its particulars. The butterfly wing, for instance, Alexander has not described this as a symbolic or dreamlike image, the kind of symbolic imagery that a psychoanalytically literate mind might generate from its stored material. He has described it as a physical surface, something with a specific color and a specific material quality, wide enough to sit on, present in the way physical surfaces are present, rather than the way objects in dreams are present, which is to say present without the flickering or shifting or substitution that dreamlike imagery produces. He has pressed on this distinction repeatedly because it bears on his argument that the experience had a vividness and a stability and a specificity that put it outside the category of anything his brain had produced in 40 years of ordinary dreaming. At the 2013 gathering of the International for 20 Quadrilli Balls, brought from the Kensreeplei, the Rollheadsvor Association for Near-Death Studies, a conference populated by researchers who have spent their professional lives in close proximity to these accounts. Alexander spoke about the butterfly wing and about the young woman's face for a room full of people who had heard many accounts but who, by various reports, attended to this one with particular care. He stood at the podium and described the color of the wing, the expression on her face, the quality of the knowing that arrived without language. The room held that specific attentive quiet that comes when an audience has stopped monitoring its own reactions and is simply following. The wing was wide. The color was something between gold and rose. The face was turned toward him with the particular attention of someone who knows the person they are looking at, knows them specifically and not in general, and is not holding the knowledge at a cautious distance. What the account conveys, even in its reported form, even held at the careful distance that is appropriate to personal testimony about events inside a comatose brain, is a quality of sustained specificity that is unusual in its own right. Most people who try to describe a vivid dream, even immediately after waking, find that the details begin to slide before the description is complete. The narrative coherence that seemed present on waking is discovered in the attempt to transcribe it to be something the waking mind constructed rather than found. Alexander's account, across years of telling, does not show this property. The earthworm's eye view has the same texture in 2015 interviews that it had in the first written notes. The gateway has the same sound. The core has the same quality of paradoxical fullness. And the face on the wing of the butterfly has the same expression: welcome, recognition, safety, love, each time it is described. None of this constitutes evidence of the kind that can be entered into a table and analyzed. The consistency of a testimony is not by itself verification of the events described. Memory researchers have documented in a different body of literature that consistent memories are not necessarily accurate ones, that the brain can hold a false memory with the same steadiness and the same emotional weight as a true one, and that the certainty with which someone describes what they remember carries no reliable information about whether the remembered thing occurred as described. This is not a minor qualification. It is the methodological challenge that sits at the center of any honest engagement with Alexander's account, and he has not dismissed it. He has instead argued that the particular characteristics of his experience, its content, its mode of delivery, its complete absence of biographical self, its relationship to the EEG data his physicians recorded, add up in combination to something that a purely brain-based explanation of its origin does not quite account for. The argument is not settled. The argument has serious interlocutors on both sides who have engaged it in peer-reviewed journals and in recorded public exchanges. And the argument as it stands now, more than 15 years after the notebook was opened and the handwriting moved carefully across the page, remains genuinely open. What can be returned to, again, is the specific and physical detail of the photograph. At some point in the weeks following his discharge, Alexander held in his hands a printed image of his biological sister Betsy, a woman he had never met, who had died before any meeting between them was possible, whose face he had never seen in any form before the illness, and had encountered, if his account is accurate, in the only place where such a meeting could have occurred. The photograph was passed to him across a table, or placed in his hands, or laid in front of him. The precise mechanics of the moment are less documented than the moment itself. And in that moment itself, and in that moment, in whatever ordinary room it occurred in, with whatever ordinary light falling across it, the face in the image and the face on the butterfly wing arrived at the same address in his awareness simultaneously, without negotiation, without the hesitation that separates a face that is familiar from a face that is known. He has described what he felt in that moment as something he is not certain any word quite reaches. Completion is the word he returns to most often. Not surprise, not the startled recognition of something unexpected, but something that felt, he has said, like the last piece of a structure falling into place, the closing of a distance that he had not consciously known was open. Whether that feeling was the recognition of something real, whether the woman on the wing of the butterfly and the woman in the photograph are the same in any sense that the word same can carry, is a question that the feeling alone does not resolve. But the feeling was real. The photograph was real. The woman in it was real, and she was gone, and he had somehow carried her face back from somewhere he had been, while lying in a hospital bed, under a mechanical ventilator, with his cortical rhythms flattened to near silence. There is something particular about that specific combination of documented facts, the EEG data showing suppressed activity, the medical record establishing the depth of the neurological compromise, and the account of a face that arrived in a place there should have been nothing, and then was confirmed in the waking world by a photograph that gives the case its specific quality of weight. Alexander has not oversimplified it. He has, in most contexts, been careful to hold the account as something that raises a question rather than something that answers one. The question is whether the experience he describes is consistent with the possibility that something was present during those 7 days that the instruments did not record and the clinical record does not contain. The question is genuinely open. It has been engaged by careful people in careful settings. It has not been closed. The notebook that he filled in the days after his awakening presumably still exists somewhere in his house or in an archive. The handwriting in it, slightly unsteady from the recovery still in progress, set down what he could in the time available before the degradation of ordinary forgetting could begin. The pages hold the earthworm's eye view in its churning dark, the gateway and its spinning white light, the core and its impossible fullness, and somewhere on one of those pages, described in whatever language he could find, a face on the wing of a butterfly in a landscape of extraordinary color turned toward him with the specific attention of someone who knows him and knew him and is holding nothing back. The photograph that confirmed that face existed somewhere in the weeks that followed, passed across a table in ordinary light, in an ordinary room, by people who did not yet fully understand what the confirmation meant to him. He held it in his hands. He looked at it, and whatever passed through him in that moment, whatever the neurological machinery of recognition, or something wider than neurological machinery, produced in him at the sight of a face he had last encountered. By his account, somewhere far from Lynchburg General Hospital, and far from any room with windows and chairs and afternoon light, it was, he has said, perfectly quiet. Not dramatic, not the kind of revelation that announces itself with force. Simply the arrival of something that had been expected, without knowing it was expected, for the entire length of time it had been absent. The face in the photograph looked back at him from a surface of paper in an ordinary room, while outside the window the world continued in its ordinary way, persistent and unhurried, moving through its own processes at the same slow pace it had maintained across the 7 days when he was gone. In a neurosurgical suite somewhere in Switzerland, in the early years of the 21st century, a conscious patient lies still on a table while a research team prepares to apply a brief and precisely calibrated electrical current to a small region of the brain's surface. The patient is awake. The procedure is monitored. The electrode is positioned at the temporoparietal junction, a region roughly at the intersection of the temporal and parietal lobes, a few centimeters above and behind the ear. The current is applied, and the patient reports, in real time, the sensation of rising from the table, of looking down at the room from a point somewhere above the body visible below, the ceiling closer than usual, the familiar geometry of the room reorganized by the unexpected angle of a perspective that should not be possible. Olaf Blanke, the Swiss neuroscientist who led this research at the École Polytechnique Fédérale de Lausanne, published these findings in the journal Nature. What his team had done was reproducible. The out-of-body sensation could be induced, paused, and induced again by adjusting the current. The patient could describe the experience as it was happening, and the description matched, in its broad character, the kind of dissociative perception that people who have survived cardiac events and other near-death crises have been reporting for decades. A sense of leaving the body, a shift in perspective, the room seen from above. What Blanke's research established was that a specific region of neural tissue, when stimulated in a specific way, can produce this quality of experience in a fully conscious, medically unremarkable person who has no reason to believe anything unusual is happening to them. That finding has not been substantially challenged. What the research did not establish, and what Blanke himself did not claim, was that it fully accounted for everything reported in cases of spontaneous near-death experience. The experiences his patients described under controlled stimulation were brief. They were fragmentary. They lacked the narrative complexity, the emotional depth, and the structured passage through distinct and differentiated realms that characterizes the accounts given by survivors of cardiac arrest and other medical crises. The temporoparietal junction, stimulated electrically in a surgical suite, produces something. Whether that something is the same kind of thing or merely resembles it at the surface is a question the research opened rather than closed. This is the condition of the field. Every serious investigation into near-death experience produces findings that matter and questions that persist. The findings accumulate in the literature, the questions accumulate beside them, and the literature, taken as a whole, is a record of careful people working at the edge of what the available instruments can measure, in a domain where the instruments themselves may not be adequate to the phenomenon they are being asked to assess. Pim van Lommel is a Dutch cardiologist who spent years working in hospital cardiac care and became interested in the reports his patients brought back from resuscitation events. Not all of his patients reported such experiences. Most did not. But enough did, and with enough consistency, that von Lommel concluded the phenomenon warranted something the field had not yet produced, a properly designed prospective study rather than the retrospective case collections that had dominated the literature until that point. Over several years, across multiple Dutch hospitals, his team enrolled 344 cardiac arrest survivors and conducted systematic interviews with each of them within a few days of resuscitation, before memories could fade or be shaped by subsequent reading or conversation. The study was published in The Lancet in 2001. Approximately 18% of the patients reported a near-death experience by the criteria his team applied. A smaller subset reported experiences that were particularly vivid and detailed: the awareness of leaving the body, encounters with deceased relatives, passage through a threshold of some kind, a quality of light and presence that patients struggled to describe in language adequate to it. Van Lommel's paper in The Lancet did not go uncontested. It has been examined, criticized, and discussed in the research literature continuously since its publication. The criticisms are serious and specific. Some researchers have noted that the 18% figure, while striking, also means that 82% of patients resuscitated from comparable cardiac events reported nothing of the kind, a fact that any complete account of the phenomenon has to hold alongside the positive reports. Others have questioned the methodology of the interview process and whether the brief window between resuscitation and initial interview was sufficient to rule out the possibility that experiences were constructed or reconstructed in the immediate aftermath of waking rather than occurring during the period of clinical unconsciousness. These are not frivolous objections. They are the kind of objections that any honest researcher working in this area has to address, and Van Lommel has addressed them, with varying degrees of success depending on which critic is reviewing the response. What Van Lommel himself argued from the data was more substantial than a simple report of the phenomenon's frequency. He argued that the findings were difficult to account for within a model of consciousness that treats subjective experience as entirely generated by, and therefore entirely dependent on, the activity of brain tissue. His patients had reported coherent, structured, and in some cases verifiable experiences during periods when their cardiac and neurological function was severely compromised. The experiences were not random or incoherent. They followed patterns. They shared features across patients who had not spoken to one another and who had no particular reason to produce similar accounts. The current neuroscientific model Van Lommel proposed may be insufficient to explain this. That is a strong claim. It is also, as of the time of this narration, a claim that has not been definitively refuted. Sam Harris, the neuroscientist and philosopher, approached Alexander's case specifically, and the NDE phenomenon generally, from a different angle, and his engagement with Alexander's book was detailed enough to be worth following carefully. Harris's central methodological objection was precise. The shutdown of measurable neocortical activity on an EEG recording does not establish that no experience was occurring at the neurological level. EEG is a surface measurement. It captures electrical patterns generated by large populations of neurons firing in synchronized ways. What it cannot capture, Harris argued, is whether smaller, less synchronized, or differently organized neural activity might be occurring beneath the threshold of what the instrument records. The vivid experiences Alexander reported, Harris proposed, could have occurred during the transition into coma or during the transition back out of it, physiological passages that EEG monitoring during the period of deepest unconsciousness would not document. This is not a weak objection. It is, in fact, one of the most technically difficult challenges facing anyone who wants to use EEG suppression as evidence that the brain could not have been generating experience during a given period. The instrument records what it records. What lies beneath its threshold remains, genuinely, unknown. Alexander has disputed this in lectures and interviews, citing the severity of the neurological disruption documented in his case, the degree of cortical involvement established by clinical observation and imaging, and the judgment of his treating physicians that the infection had compromised his neocortex in ways that went far beyond what EEG alone was measuring. The dispute is real. Neither position has been resolved by the evidence currently available, because the evidence currently available is not sufficient to resolve it. What remains, after the exchange between Alexander and Harris, is something more interesting than a winner, which is the recognition that the question of what brain states are necessary and sufficient for the generation of subjective experience has not been answered by neuroscience. Not because the question is unimportant, and not because serious researchers have not tried to answer it, but because the answer requires a level of understanding of the relationship between neural process and conscious experience that the field does not yet possess. The hard problem of consciousness, the question of why any physical process gives rise to subjective experience at all, sits beneath the NDE debate and makes every specific claim about what a given brain state can or cannot produce harder to settle than it might initially appear. Kevin Nelson, working at the University of Kentucky, proposed a specific neurological mechanism for near-death experiences that has received considerable attention in the research literature. Nelson's hypothesis centers on REM sleep intrusion, a phenomenon in which the neurological machinery of dreaming, which normally activates during sleep and suppresses during waking, bleeds into waking consciousness under conditions of extreme physiological stress. In normal REM sleep, the brain generates vivid and coherent visual and experiential content, while the body is paralyzed and disconnected from external sensory input. Nelson found in a study published in the journal Neurology that people who had reported near-death experiences showed a significantly elevated rate of REM intrusion phenomena in their ordinary sleep patterns compared to controls, things like hypnagogic hallucinations at the edge of sleep, sleep paralysis, and other markers of a neurological system in which the boundary between waking and dreaming states is more permeable than usual. Nelson's hypothesis is specific and testable in ways that some other NDE explanations are not. It proposes a documented physiological mechanism, REM intrusion, and links it to a measurable feature of the experiencer population, elevated REM boundary permeability, that can be studied in the laboratory. The study's findings are real. The elevated rate of REM intrusion phenomena in NDE experiencers compared to controls is a finding that exists in the published record. What the hypothesis does not straightforwardly account for is the content of the experiences, the specific structured narratives, the encounters with deceased persons who were unknown to the experiencer at the time, the quality of the experiences as reported being more real than dreaming rather than resembling dreaming, and the subset of cases in which experiencers have reported accurate perceptions of their physical environment during periods of clinical unconsciousness that were later corroborated by medical staff or family members. Nelson's mechanism may account for the form of the experience. Whether it accounts for its content is a separate and still open question. The philosophy of mind has its own stake in this territory, and its engagement with the question is older and in some respects more foundational than the neurological debate. David Chalmers, the Australian philosopher working at New York University, introduced the formulation of the hard problem of consciousness in a paper presented at a conference in 1994 and developed it in his book The Conscious Mind, published in 1996. The The hard problem is not the question of how the brain processes information, generates behavior, or integrates sensory signals. Those questions Chalmers calls the easy problems, not because they are simple, but because they are in principle tractable by the methods science already possesses. The hard problem is the question of why any of this processing is accompanied by subjective experience at all. Why does it feel like something to see red, or to hear a voice, or to hold a thought in mind? Why is there an inner life, rather than just information processing in the dark? Chalmers has noted in the academic literature on consciousness that near-death experience cases do not constitute proof of the survival of death, or of any specific metaphysical claim about consciousness. He is careful about this, but he has also noted that these cases and the research program they have generated represent a genuine empirical challenge to purely reductive accounts of consciousness, accounts that treat subjective experience as nothing more than a byproduct of physical processes in brain tissue, fully explicable in principle by a sufficiently complete description of those physical processes. The challenge is not that NDE reports prove reductionism wrong. The challenge is that the hard problem of consciousness means we do not yet have a satisfactory reductive account of even ordinary waking experience. And NDE cases add pressure to a question that was already unsettled before any specific near-death report entered the discussion. This is the wider frame in which Alexander's case sits. It is not a frame that resolves his specific claims. It is a frame that places them in a context where the foundational questions, what consciousness is, where it comes from, what relationship it bears to the physical tissue that seems to generate it, are genuinely and seriously unresolved by the people whose professional work is to resolve them. Chalmers is not a mystic. He is a rigorous analytic philosopher whose work is published in the best journals and engaged with by serious colleagues. His position is not that NDE reports prove something beyond the brain. His position is that we do not yet have a complete theory of consciousness that would allow us to confidently say what the brain can and cannot generate under any given set of conditions. There is a specific quality to the research literature on near-death experiences that is worth attending to, not what it concludes, but what it looks like as an accumulated body of work. It is large. It goes back decades. The names in it are not fringe figures. They include cardiologists, neurologists, psychiatrists, philosophers, and cognitive scientists working at institutions with established research reputations. Raymond Moody, whose 1975 book, Life After Life, introduced the phrase near-death experience to a wide audience, was a physician and philosopher who gathered retrospective accounts. Kenneth Ring, a psychologist at the University of Connecticut, developed systematic interview methodologies and published prospective research across the late 1970s and 1980s. Bruce Grayson, a psychiatrist at the University of Virginia, developed the Grayson scale, a standardized instrument for measuring the depth and characteristics of near-death experiences that has been used in dozens of subsequent studies and that gives the research field a shared language for comparing cases across populations. The field is imperfect. Its methodologies have limitations. Its findings have been disputed. But it is not a fringe field. It is a research program that has been running for 50 years, producing findings that take a specific form, generating hypotheses that are being tested, and arriving at a set of questions that the available science has not yet answered. Alexander's case sits inside this research program as a specific and contested instance. He is contested not only because his claims are large, and they are large, but because of who he is. A trained neurosurgeon with a Harvard faculty appointment, who taught for years the very model of consciousness that his own reported experience appeared to challenge, is a different kind of witness than a layperson with no scientific background. His professional identity shapes how his account is received on both sides. For those inclined to find his experience meaningful, his credentials make the account harder to dismiss. For those inclined to find it neurologically explicable, his subsequent advocacy for a particular spiritual interpretation of the experience and the commercial success of his book raise questions about motivated reasoning that deserve to be held as part of the full picture. The Esquire investigation, published in 2013, raised specific concerns about the accuracy of some of the medical details in Alexander's book. The investigation interviewed physicians and reviewed elements of the clinical record. Some of the doctors involved in his care offered accounts of the medical circumstances that differed from the picture Alexander presented. These concerns are real and documented, and they matter to any honest assessment of the case. What they do not do, and what the investigation itself did not claim to do, is establish what Alexander did or did not experience during the 7 days of his coma. The question of the accuracy of specific medical claims in a published book, and the question of what a person's subjective experience consisted of during a period of severe neurological compromise, are related questions, but they are not the same question. One can be assessed by reviewing documents and interviewing physicians. The other remains, in the strictest sense, inaccessible to third-party verification. What persists in this case, after all of the scrutiny, is a structure of genuine uncertainty that neither the advocates nor the critics have fully dissolved. The EEG data exists, the Glasgow Coma Scale scores exist, the cerebrospinal fluid culture results exist, the clinical notes from Lynchburg General Hospital exist, filed in the record system with the admission date of November 10th, 2008, and the days that followed recorded in the dense-specific language of a medical chart that was not written for any audience other than the medical team managing a critically ill patient. These documents are not Alexander's construction. They are not a spiritual narrative. They are a bureaucratic record of a body in serious physiological trouble, monitored by instruments, managed by physicians, watched by a family that had been told to prepare for the possibility of loss. The EEG traces from those 7 days, if they could be laid flat on a table beside the traces from a healthy waking brain, would show a visible difference: the suppressed waveforms, the flattened rhythms, the absence of the busy oscillating patterns that characterize a brain operating at normal function. That difference is real. What it means for the question of whether experience was occurring during the period those traces were generated is the question that the available science cannot yet answer with confidence, and that is not because scientists have not tried, but because the relationship between neural activity and subjective experience is precisely the question that the hard problem of consciousness identifies as the most foundational, unresolved question in the entire science of the mind. The neurosurgical suite in Switzerland, where Blanqui's research team applied the electrode to the temporoparietal junction and induced the sensation of leaving the body, is one point of reference. The Dutch hospitals where Van Lommel's team interviewed 344 cardiac arrest survivors within days of resuscitation is another. The University of Kentucky, where Nelson found elevated REM intrusion in NDE experiencers. The University of Virginia, where Grayson has spent decades building a research methodology careful enough to be taken seriously by people who would prefer a simpler answer. The lecture rooms where Chalmers has returned, year after year, to the problem that he named and that remains named because it has not been solved. These are the landmarks in a landscape that Alexander's case sits inside, and they give his case more context than it often receives in the popular discussion, which tends to oscillate between full endorsement and full dismissal without spending much time in the territory between. That territory between is where the actual research lives. It is not a comfortable place to stay. It does not offer the satisfaction of a resolved question. It offers instead the particular quality of attention that comes from following something genuinely difficult across a long time through the work of many careful people and arriving at the recognition that the question is still open, not because no one has looked at it seriously, but because it is the kind of question that the serious looking has, so far made more precise rather than simpler. The case file for Eben Alexander's hospitalization is still held in the record system at Lynchburg General Hospital. It has an admission date, November 10th, 2008. It has the EEG data from the days his brain's electrical rhythms were suppressed beneath the level that instruments typically associate with conscious function. It has the laboratory culture results confirming the EEG data, deheresy, like the CMUP, coli pathogen, a gram-negative bacterium that almost never causes this kind of meningitis in a previously healthy adult. And yet, on that particular November, in that particular person, did. It has the Glasgow Coma Scale scores entered in the patient chart by the nurses and physicians who monitored him across the 7 days, the numbers at the low end of the scale recording the absence of meaningful response. It has the record of antibiotics adjusted to the sensitivity profile of the identified organism, the mechanical ventilation, the fluid management, the adjunctive corticosteroids given to reduce the inflammation in the meningeal tissue surrounding the brain. It has a discharge date. It has the name of a patient who left the hospital in a state that his treating physicians had considered extremely unlikely. That file does not contain a record of what Alexander experienced during those 7 days. No file could. The instruments that generated the data in that file measure things that instruments can measure: electrical rhythms, physiological parameters, bacterial presence in cerebrospinal fluid, the scoring criteria of a standardized neurological assessment. They do not measure the presence or absence of subjective experience because no instrument has yet been designed that can do that. The hard problem is not merely a philosophical formulation, it is a practical limitation on what the medical record can contain and what it can, in principle, tell us. This is the condition in which Alexander's account exists. Not proven, not dismissed, held in the open space between the documented clinical record and the limits of what any documentation can reach. The research around it is real. The instruments that produce the data are real. The questions that the data raises and fails to answer are real. The experience Alexander reports having had is his, and it is not available for independent verification, and it is also not available for independent refutation, and it is also not available for independent refutation, because the question of what a severely compromised brain can generate, or what consciousness is, where it resides, whether it can persist when the tissue that ordinarily generates it is under the kind of assault Alexander's was, is a question that the best available science has not resolved. Somewhere in the record system at Lynchburg General, the file remains. The admission date, the EEG traces, the culture results, the coma scale entries, the careful, dense daily record of a body in crisis, monitored through the days until the morning of November 17th, 2008, when the monitoring showed something it had not shown on any of the previous mornings. The record is still there. The question it cannot answer is also still there. Both of them persist alongside each other in the particular quiet of things that have been carefully examined and not yet explained. The research continues in other rooms, in other hospitals, with other patients, other instruments, other careful people, following the same difficult questions that this case opened and that 50 years of the field's best work has refined without resolving. Van Lommel's perspective data sits in the archive of the Lancet. Blanca's electrode work persists in the literature on the neural substrates of self-perception. Nelson's findings on REM intrusion remain in the record of what has been measured and documented. Grayson's scale continues to provide the research field with a common language for comparing experiences that otherwise resist comparison. Chalmers's hard problem remains on the whiteboard, the phrase still written in marker at the beginning of each new semester's first session, the question at its center still waiting for an answer adequate to it. The world goes on, being the kind of place that produces these cases. People survive events that their physicians did not expect them to survive, and some of them return with accounts of experiences that the medical record, taken alone, does not explain. The accounts share features across cultures, across languages, across decades of independent reporting. They are consistent in ways that demand attention and inconsistent in ways that resist tidy summary. The research that has followed them is imperfect and ongoing and serious. The questions it has raised are some of the most fundamental that the study of consciousness can approach. Questions about what experience is, where it comes from, and what relationship it bears to the physical matter that seems to be its ordinary home. None of those questions are answered tonight. They are held here, in the quiet, in the same condition they have been in for a long time, genuinely open, carefully attended to, resting in the particular stillness of things that have not yet resolved. The file at Lynchburg General holds its admission date. The EEG traces hold their suppressed waveforms. The research literature holds its accumulated findings and its accumulated questions.